So good evening, friends. Good evening, friends. Today's topic is about oxygen therapy. It is my great pleasure to introduce my good friend and colleague, Dr. Venkatesh Gupta, who is a senior consultant in intensive care medicine at Aster Whitefield Hospitals, Bangalore. Dr. Venkatesh, as we already mentioned, he'll be talking about oxygen therapy. And oxygen therapy is a very, very important thing. We know that it's one of the most important common medicine which we all use in the ICU. We should know how to measure the oxygen that what we are giving, how much oxygen we need to, how much we need to deliver in each and different, disease conditions. And I just request Dr. Venkatesh Gupta to start this session.
Thank you, Dr. Rajit. Thanks for the introduction. I'll be sharing my screen now. Just let me know if it is visible. Is my screen visible?
Yes. Yes, very well.
Just once. Yeah. So good afternoon, all. I will be talking about oxygen therapy in the ICU. As Dr. Rajit said, has to be used like a drug. Oxygen is nothing but one more drug in our armamentarium of so many medications. Next 30 to 35 minutes, I'll be taking you through a little bit about oxygen transport, indications, little more in detail about the oxygen delivery devices, complications of oxygen therapy. And as has been instructed, this is not just a one-sided lecture. I have put few MCQs. I request all of you to answer those MCQs in the form of chat box. You can use your chat box to answer whether it is your option is A, B, or C, or D. Okay. So why is oxygen required? For us to survive, we need oxygen. So how are we going to do that? We are going to basically extract the oxygen from the atmosphere, transport through the blood to the cells for various metabolic processes. What is that metabolic process? Say, for example, oxygen, it's a continuous process that oxygen is available and we are utilizing it. And there is aerobic metabolism that is happening in the presence of oxygen, which leads to production of this ATP, adenosine triphosphate. That is, we can see that it is almost like that in the aerobic metabolism, 36 ATP is produced, which is the energy source for all the cells and indirectly for all the organ function. When there is lack of oxygen, all the organs do sustain the aerobic metabolism for only for few minutes, but then it will switch to anaerobic metabolism for the energy source, because of which there will be lactate accumulation. So further, if there is lack of oxygen, then that anaerobic metabolism will have certain ability and that will also stop, and you will see the consequence of lack of oxygen in relation to any of the organs. So just introduction of few terms to you, you may all be aware. What is oxygen therapy? It is administration of oxygen in excess concentration, what is already there in the more than what is there in the ambient air, that is atmosphere. So it is the amount of oxygen, the fraction of oxygen that we are going to give to a patient is called FiO2. You can talk it as partial pressure, but we all know that what is FiO2 on the ventilator. Suppose the patient is on 50%, you call FiO2, fractional inspired oxygen is 50%. That is called FiO2. And the amount of oxygen at the level of alveoli, we always call capital A, that is PaO2, capital A. That needs different formula to calculate, not the one which is regularly done on the bedside. Then the PaO2, very important. Where do you see the value of PaO2? You see the value of PaO2 on ABG. So before I go ahead with further information, I just have one question. Can I expect you people to answer it? Type your options, either whatever, if it is 1, you put it as 1 on the chart box. If it is 2, you put it as 2 on the chart box. Like that, you replay the question. What is the oxygen concentration in atmosphere that we generally breathe? Can somebody type it? Sorry. I think I did a mistake. Or I'm unable to see the chart box. 21%. Okay. Yeah, 3. Many have typed you as 3, 21%. Excellent. So that is the answer. 21%. That is the concentration of oxygen in the ambient atmosphere. So I will introduce the concept of oxygen cascade to you. Every air, every gas has certain amount of pressure in the atmosphere. So in the atmosphere, similarly, the oxygen has a pressure of 159 mm of Hg. We call it as partial pressure. When it reaches the lower respiratory tract, it reduces to 150. Similarly, at the alveolar level, it is 104. And at the blood level, it is venous. On the arterial side, it is 100. On the venous side, it is 40 because of tissue extraction. From the arterial blood, when it enters the mitochondria, that level comes down to 7 to 37. So this decline in the oxygen tension from the atmosphere to mitochondria is called as oxygen cascade. Why is it important? In any of the disease conditions, each step can take a bigger role. Okay. So then comes the important concept of oxygen transport. Once you inspire the air, that is the oxygen, enters the lung, that enters the blood. In the blood, we calculate it as arterial oxygen content of the blood. Then that has to be delivered to the tissue level. So how is that delivered? That depends on the cardiac output, hemoglobin concentration, and saturation of the hemoglobin. Okay, that totally put together determines the oxygen delivery. Next comes the consumption, how much oxygen is being taken up by the peripheral tissues. Then oxygen extraction ratio we call, which keeps changing depending on whether the patient is resting, whether the patient is exercising, or patient is having some disease process ongoing. So that depends on the supply and utilization demand. So next question here, how is oxygen carried in the blood? The larger portion of oxygen is in the dissolved form in the blood. Larger portion of oxygen is bound to hemoglobin in the blood. Oxygen is not bound to hemoglobin. None of the above are correct. Can you please type your answer? I can see many replies as 2. There is one reply as 1. Again, many have chosen 1, and largely many have chosen 2. Somebody has mentioned it as 3. 1, 1, 3 is what I am seeing. I'll not wait for more. The answer would be 2, because what happens? The larger portion of oxygen is bound to hemoglobin in the blood. Almost close to 97% of the oxygen is carried in the blood by the bound form. Okay, we'll come to the oxygen content. See, the larger content of the blood is bound to hemoglobin. Each gram of hemoglobin carries 1.34 ml of oxygen. Okay, so if it is 100 ml, 20 ml per deciliter of oxygen is carried by the blood. Once it reaches the venous side, it will become 15. So it consumes around 5 ml. So remember, the larger portion of the oxygen which is carried in the blood is bound to hemoglobin. So next question, what happens if you give more oxygen than required? We get more oxygen into the blood, we get less oxygen into the blood. There is no significant increase in the amount carried by hemoglobin when it is already more than 95% saturated with oxygen. None of the above. Can you all type your answer? What happens if you give more oxygen than required? Say you are giving 100%. Is it going to change the oxygen content in the blood? I can see 1, 2, 3 as replies. 3, 2, 1. Okay. 3. There are a lot of 3s. That is true. Answer 3 is correct. There is, once you administer adequate oxygen, beyond that, if the hemoglobin is saturated more than 95%, already saturated with more than 95%, there cannot be any further increase in the amount of oxygen carried by the hemoglobin. So what is oxygen delivery? It is the amount of oxygen that is getting delivered from the blood to the tissue level. So that depends, as I said, depends on the cardiac output, hemoglobin concentration, and of course the saturation of the hemoglobin. That's why cardiac output is also important. Hemoglobin concentration is also important. Next is oxygen consumption. So oxygen delivery, every 1000 ml of blood carries around 200 ml of oxygen. Similarly, if we assume that around 5 liters of the blood, so close to 1000 ml of oxygen is carried per minute. And consumption is close to 250 ml, almost like 1/4 of the quantity is utilized. So when it reaches the venous side, it is around 70% left. So 25% of the arterial oxygen is used every minute, 70 to 75% is left behind. That we call it as mixed venous oxygen saturation. So this is the picture of consumption. Can you all see, or my chart box is interfering? No. You can all see the graph. So what it says is, generally the 25% of the oxygen is consumed at rest. If suppose the demand increases like 30%, 40%, 50%, till then, somebody has raised hand. Is there any concern? Is there any concern? Once it reaches above 50%, you have to supply oxygen. Otherwise, the body cannot cope up with the supply demand, increased demand. This is oxygen hemoglobin dissociation curve. It is a percentage of the oxyhemoglobin and the content of the PO2, which is closely related. I'm not going to talk about this. I request all of you to go and read because of lack of time. We have many more slides to cover. Goals of oxygen therapy is to correct hypoxemia and maintain tissue oxygenation. What is hypoxemia? Reduced oxygen content in the blood. Okay, and to decrease the symptoms of hypoxia and hypoxemia, let us see what is that, and minimize the cardiopulmonary workload. Whenever there is huge demand, the work on the heart and lung will further go up because it will struggle to get the supply. So indications for oxygen therapy: documented hypoxemia as evidenced by PaO2 less than 60 or SaO2 less than 90 on room air, or PaO2 or SaO2 below any desirable range for a specific situation. Any acute care situations in which hypoxemia is suspected, severe trauma, acute MI, or it can be short-term therapy like post-anesthesia period where you administer oxygen only for a few hours. Then long-term oxygen therapy in terms of, say, for example, COPD patients or interstitial lung disease patient where they need small quantities of oxygen at home. So how do you assess? One is by the monitoring system, the other one is clinical assessment. Clinical assessment, you see all the signs and symptoms of hypoxia. It can be CNS symptoms like restlessness, headache, confusion, or cardiovascular like rapid increase in the heart rate, respiratory in terms of tachypnea, anxiety. There can be, if the symptoms become more severe, the heart rate may start reducing, extreme restlessness, and then cyanosis. So if you are utilizing ABG, then you look at PO2. Any PO2 of less than 60 is a strong indicator for oxygen therapy. Anything less than that causes much more worse symptoms like memory loss, bradycardia, cardiac arrest. PaO2 less than 30 can cause cardiac arrest. 60 to 80 is borderline. 80 to 100 is considered normal. Or if you're monitoring SpO2, you all know anything less than dropping, the relatively dropping oxygen saturation levels are a matter of concern, or anything less than 92, 90 in a person who is having bad health is always a matter of concern. Let us come to oxygen delivery systems classification. We largely design oxygen delivery systems based on the design or performance. If it is a design, whether they are providing only low flow oxygen, or they are utilizing some kind of reservoir to provide oxygen or concentration, or whether it is high flow, very high flows of oxygen like 20 liters, 30 liters, depending on the type of device. Next comes the performance, whether you can fix the percentage of oxygen that you are giving. That is called fixed oxygen performance devices. If you cannot control it, or if the patient effort or various patient factors come into picture when you are providing oxygen and the oxygen concentration is not fixed, then it is called variable performance device. So these are few devices across all the stages. The only highlighted ones I'm going to talk because those are the ones which are largely used. Okay, so we move forward. I'm not going to read out this. So what happens in low flow oxygen systems? Here in low flow oxygen system, the oxygen flow is less, like 5 liters, 8 liters, or less than that. And but that would generally not meet the patient's inspiratory flow demands. Whenever the patient is ill or sick, the inspiratory flow demands are much more higher. So by providing low flow oxygen, you are not meeting the patient's demand. So how does the rest of the oxygen comes or the airflow comes? It is the room air that makes up the remainder of the patient's tidal volume. So here, the fractional inspired oxygen varies with the patient's tidal volume, respiratory rate, inspiratory effort, and ventilatory pattern. So in any low flow oxygen systems, the delivery will be low and FiO2 will be variable. So we call it variable performance device. So one such low flow device is nasal prongs. I'm sure you all would have seen and used nasal prongs. So how much maximum oxygen you can administer through nasal prongs? Can you please reply by typing the answer? I can see 2 replies. Go ahead. All of you type. Many have typed as option 2.
Most people have opted for 2.
Yeah, most people have opted for 2. Excellent. Somebody has mentioned 3 also. And one person has mentioned 1. 1 or 2 people have mentioned as 1. So the answer is 2. The correct answer is 2. We will learn more about it. So I'm sure you all would have seen. 1 second. I'm able to see the slideshow. Yeah. Most of you would have seen and used the nasal cannula. You all know that it has a prongs of 1 centimeter long, which goes and sits into the nasal vestibule. And FiO2 is largely 24 to 40%, not more than that. And the flows, what you can use is not more than 5 liters. You can't use 6 liters, 7 liter and all that. Generally 1 to 5 liter you can use comfortably in adult, and preferably less than 2 liters per minute in child. This is per minute, whatever I'm talking. So the merits are it is easy to fix, keeps hands free, not much interference with further airway care. Now the mouth is free, its cost is very cheap, and it's very compliant. The demerits are it is unstable, it can come out. The percentage of oxygen you are not sure. Easily it can be dislodged. If you keep the more the flow, the more is the discomfort for the patient. It can cause nasal trauma, mucosal irritation, lot of dryness. You prefer to use humidified oxygen whenever using this kind of devices. But well, they are not very efficient mechanisms, of course. And FiO2 can be inaccurate and inconsistent. So how do you estimate the FiO2 provided by nasal cannula? So we have a rough pattern. As you all have answered already, the room air atmosphere is 21%. For every 1 liter you increase above the room air. So if you are giving 1 liter through the nasal prongs, he's getting extra 4% of oxygen. Say it is 21%, now you are giving 4, it is close to 24 to 25%. Like that, each liter per minute of nasal oxygen increases the FiO2 approximately by 4%. That is a rough understanding. For example, if you are giving 4 liter per minute, 24 4 4s are 16%, 16 plus 21. So that is the amount of oxygen you are getting, roughly around 37% to 38%. So remember this, 1 liter in excess provides 4% FiO2 in excess. Next comes the reservoir system. Here what happens? It's slightly, nasal prongs has no reservoir system. These systems will have small reservoir where there is small amount of oxygen accumulated over there and provides little better FiO2. It can be, that reservoir can be less than the tidal volume or equal to tidal volume of the patient. Delivers moderate to high FiO2 compared to the nasal prongs. This is also variable performance device because it again depends on the patient's effort. And to provide a fixed FiO2, little higher FiO2, the reservoir volume should exceed the patient's tidal volume. If you consider the patient's tidal volume is 500 ml, then the reservoir, the amount should be more than that to have some consistency in the FiO2. I wouldn't call it a fixed device though. Then the reservoir masks. These are the most common types of reservoir devices are simple face mask. You all know, we also call it as Hudson mask. Then the partial rebreathing masks and non-rebreathing masks. We'll see the differences amongst these three. This is a simple face mask. You see there are exhalation ports. There is one stabilizing nasal bridge, metallic thing which supports the nasal bridge, gives that stiffness to the shape. Then one oxygen inlet, and you know that it can be tied around the head. This reservoir is hardly 100 to 200 ml. This is of course a variable performance device because FiO2 varies with oxygen input, how much you are giving, and the mask volume, extent of the air leakage, patient's breathing pattern. If it is only 100 to 200 ml of reservoir, if the patient is taking 500 ml, from where the excess air will come? It has to come from the atmosphere, which is low in concentration. So you cannot control the FiO2 here to a reasonable extent. So the minimum flow here would be 5 liters. You can't use less than that because it can lead to rebreathing of the carbon dioxide. So CO2 can go up. So it has to be more than 5 liters. But beyond 8 liters, you cannot increase the oxygen concentration. There is no point in putting simple face mask and increasing your oxygen to 15 liters. You understand? There is no benefit. You can't give more than 60% with this simple face mask. So as well, put not more than 8 liters on the simple face mask. Merits are moderate but variable FiO2, 40 to 60%. Good for patients with blocked nasal passages and mouth breathers. Avoids nasal trauma, easy to apply. Well, it's of course can cause little uncomfortable, at least till the patient gets used to it. It can interfere with further airway care. Proper fitting is required. Risk of aspiration is there. Suppose the patient's consciousness is reducing. Then if you put less than 5 liters, it can definitely lead to rebreathing of the expired gases. CO2 can go up. So this is a rough percentage of the FiO2 when you are providing face mask. So it delivers only between I'm not sure if you're able to see 40. Maximum is 5 to 8 liters. Maximum is 8 liters. 40 to 60% is the oxygen. Then comes the reservoir mask. The left one on the side is partial rebreathing mask. There are no valves on the expiratory ports. There is no valve near the reservoir. Whereas in the non-rebreathing mask, there are valves. You can see that I have labeled it. There are valves both near the expiratory port as well as near the inhalational area, inspiratory port. The partial rebreathing mask can provide 50 to 75% of the oxygen, and the maximum amount of oxygen you can deliver will be 11 liters. You can provide anywhere from 8 to 11 liters. Beyond that, it is not going to increase your oxygen concentration. So this is the same thing. There are no valves here. Once the patient starts expiring, the whatever oxygen he is taking, that and as well as first 1/3 of the exhaled gas, which will be called anatomical dead space, enters into the bag. And the last 2/3 of the exhalation escapes out through the side ports. During inspiration, the first exhaled gas and oxygen are inhaled, which makes up close to 60 to 80% of the oxygen. And fresh gas flow can be more than 8 liters, but definitely benefit may be less if it is more than 12 liters. And make sure that the bag is inflated all the time to achieve highest FiO2 and prevent CO2 rebreathing. This is a non-rebreathing mask. As I said, this will have three valves. One will be at the inspiration, 2 expiratory valves. They're all unidirectional valves. When you are expiring, the expiratory valves prevents the air entrainment. There is no air entrainment happening through the side port. At the same time, inspiratory valve prevents exhaled gas to go into the reservoir bag. So whatever oxygen gets in, that is only oxygen and not the exhaled gas. So FiO2 can reach from 80 to 90% and sometimes 100% also. So to deliver 100%, the bag should remain inflated all the time, and fresh gas flow should be at least 10 liters, and it can go up to 15 liters. Here again, depends on the patient's respiratory breathing pattern. Next comes the high flow system. The gas flow is sufficient to meet. Here, the flows are so high, it meets the peak inspiratory demand of the patient and also meets the minute ventilatory requirement. So FiO2 is independent of the patient's ventilatory pattern, whether he is breathing, shallow or good effort, it doesn't matter. FiO2 is always dependent on the device performance. It delivers low to moderate and fixed FiO2. And these are all, because it is a fixed FiO2, we call it fixed performance device. The best example would be Venturi mask, or you call it Venti mask. It is based on the Bernoulli principle. I'll explain you in simple terms. Here you can see the yellow arrow where the oxygen is entering through the small tube. Then suddenly the aperture opens up into a little bigger space, where there are holes on the side. So what the Bernoulli principle says is, whatever enters in speed through a narrow orifice, opens up into the atmosphere, causes fall in the pressure. Because of the fall in the pressure, the air gets entrained from the side apertures. So how much air gets entrained depends on the size of the aperture. The larger the aperture, the more is the air entrained, the more air enters into the mask area. So the FiO2 will be low. Suppose the aperture is small, so the pressure drop is same. Okay. Of course, that depends on how much gas you are providing, how much gas is going through the narrow tube. Once it opens up into the aperture, bigger aperture, there is a fall in pressure. The fall in pressure is again same. The amount of air that gets in because of the fall in the pressure depends on the side apertures. The bigger the aperture, more is the air which comes in. So the less is the FiO2. The smaller the aperture, the more is the FiO2. That is the principle we always use in Venturi mask, or you call it Venti mask. Jet orifice, FiO2 is regulated by the size of the jet orifice and air entrainment port, we call it. Again, FiO2 is low to moderate, 0.24 to 0.6. High flow fixed performance device. There are again two models. There is a variable FiO2 model and the fixed FiO2 model. You use the color coded. You might have seen both kind of Venturi masks. These are different. You can see the different color caps which can be connected to the mask. Each one has a fixed aperture. Either you use that, or you use where you can control the aperture size. You can reduce the aperture size or increase the aperture size. And based on the number of liters, you have to you can know what is the amount of FiO2 you are delivering. Next, and where we use this? This we use in COPD patients. You don't want to give too much of oxygen to COPD patients. Stable COPD patients or reasonably stable COPD patients. If they're severely hypoxic, we do not worry about this concept, what I am telling. COPD patients, hypoxia is the ventilatory drive for them. The brain is tuned for the hypoxia. The moment you start giving more oxygen, they may stop breathing, leading to excess CO2 accumulation. So what will happen? You try to achieve only 88 to 92% of the oxygen in COPD patients. This is the standard practice we always do. So that you are not depriving them of the hypoxic ventilatory drive, which they are tuned to. But if the same patient is very hypoxic, I do not hesitate to give more oxygen because he may need further ventilatory support in the form of NIV or intubation. Otherwise, any conscious patient with little bit of stress, hypoxic, you aim only 88 to 92% in a COPD patient. This is not applicable for any other patient. Next is high flow nasal cannula, we call HFNC. I am sure you would have all come across this device, especially during the COVID time. There is a gas blender where you can provide up to 100% of the oxygen. You need a central oxygen supply for that. You cannot use the simple oxygen flow meter. If you use simple oxygen flow meter, you cannot give beyond 15 liters. Whereas this gas blender with central oxygen supply can provide up to 60 liters per minute flow. Okay, because if the patient is very sick, the inspiratory flow demand will be close to 40 to 60 liters, which this device meets. The flow demand is met by this kind of device. There are special, provisions in this. Good amount of humidification. There is a heater humidifier. Then the patient side, which you connect to the patient. It comes with a soft nasal pillow kind of thing, which you put it below the nose. It's almost like nasal pump, little more sophisticated device. So the mechanism of action is, it is non-invasive oxygenation, precise and more higher FiO2, close to 100% you can provide. Warm and humidified gas. Uses minimal PEEP. It provides around 3 to 5 mm of Hg of positive end expiratory pressure. Reduces the dead space. Decreases the work of breathing. What do you set up in this device is flow rate. You set up the flow rate. It can be 30 liters, 40 liters, 50 liters, can go up to 60 liters. Beyond that, this device probably may not help much. Then probably you may consider putting them on ventilator if the flow demand is much more. Then FiO2, you can provide up to 100%. Then there is humidification fluid, which you should always check, because it is based on that. Otherwise, patient will start feeling very uncomfortable if you don't have humidification fluid. Then the temperature, you can set the temperature, then appropriate size cannula. So roughly around 35-degree temperature, 30 to 40 liters of flow, 60 to 70% of FiO2 to begin with, or start with high and then slowly reduce, is probably a reasonable way of setting up the high flow nasal cannula. So now that we spoke so much about oxygen therapy, is it devoid of any complications? Definitely not. They can always have side effects of every drug. Similarly, oxygen will also have complications of excess therapy. It can lead to oxygen toxicity. As I said, excess oxygen in a patient with COPD can depress ventilation and lead to type 2 respiratory failure, worsen carbon dioxide levels, because they are tuned to hypoxia, certain amount of hypoxia. The moment you give more oxygen, that drive is gone, which acts at the level of the brain. Then in kids, you are providing very high oxygen concentration. It can cause retinopathy of prematurity. Then something called absorption atelectasis. You provide more oxygen, the dilated alveoli can get collapsed and lead to absorption atelectasis. And at times it can lead to fire hazard also if you are providing unnecessary oxygen with risk of combustion. Then symptoms of oxygen toxicity, as I said, it can be visual field loss, especially in kids, retinopathy of prematurity. and others are not very important. Muscle twitching, seizures, jerky breathing, irritation, coughing, shortness of breath, tracheobronchitis, acute respiratory distress syndrome. These are all important when you are not providing appropriate therapy, but these are all not important, not very important when the patient is extremely sick and struggling with hypoxia. He's having very low oxygen saturation. You cannot think that oxygen can cause toxicity and you cannot not give him oxygen. No. So my presentation ends here. I can see few of you have raised hands. Can you type your question or can they talk also?
Yeah. So thank you, Dr. Venkatesh, for the excellent presentation. So as we have mentioned, that oxygen is a very, very important drug in the ICU, drug in the medical field. So we all should know what are the indications for oxygen delivery, what are the indications, what are the contraindications for oxygen, and how to measure oxygen, how much oxygen we are giving. Like any other drug, how much we are giving, you should know. And, as Dr. Venkatesh has mentioned, there are, the oxygen delivery devices are there. They are fixed delivery devices and variable delivery devices. So we use nasal prongs. We can comfortably use up to around 4 liters to up to 5 liters maximum. You can go by the nasal prongs. So beyond that, you use the mask. Then non-rebreathing masks are there. So these are all, non-rebreathing masks, or are, variable delivery devices. We have fixed delivery devices. We have, the Venturi mask is there, and we know the HFNC, and so this is, now this is open for, questions. Any questions other you can put in the chat box, and we'll be discussing that. Any questions?
Somebody has raised hand. Darshan Makwana.
Maybe unknowingly, I presume, yeah. Manju, any question is there? Solangi, Nikki, Vasava, Sakil, Shabana, Sunny, Rathod, Kushbu. Any questions?
I can see 1 or 2 doctors also, Dr. Chaitanya.
Yeah. Yes, Shirley, please ask.
There is one question. Patient is on non-rebreathing NRM mask and he is a COPD. How can we manage, sir?
Yes.
Ideally, putting an NRM mask on a COPD patient is probably not the ideal thing unless he's very hypoxic. You should always see how stable the patient is. Try to optimize medication like bronchodilators, antibiotics, mucolytics, and all that, and see whether the oxygen requirement is going up or coming down. The best would be to provide them non-invasive ventilation and continuously monitor them in terms of SpO2 of 88 to 92% and oxygen, ABG, of course, ABG, look at the trend of carbon dioxide. If he receives appropriate therapy and if he's a responder, we see that his oxygen saturation reaches over a period of next 12 to 24 hours, reaches certain stability. Then CO2 should also start coming down. Then he is on the appropriate therapy and of course, he is a responder. If that is not happening, if he is very hypoxic, then the next stage would be ventilation, invasive ventilation. Of course, when we start them on non-invasive ventilation, most of the times over the first 24 hours, only a few hours of NIV free time we give, just to eat, drink, or little bit of rest. Otherwise, you continue them on NIV for first 24 hours, then slowly increase the breaks. Using NRM mask, NRM is, I assume, NRBM, non-rebreathing mask, is not an ideal thing to do in a COPD patient. Ajit sir, you have any answer for that?
Yeah, so that's the thing. In COPD exacerbations, so we are we are looking at a saturation of around 88 to 92. So the vast majority of the COPD patients, they are used to a low oxygen because 80 to 92%, the saturation is more than okay for them. If you give more oxygen, supposing as you mentioned, if you put an NRBM mask and all, which can, kind of uncontrolled, very high delivery of oxygen, if you give, the carbon dioxide also will go up. So such patients, in those patients in COPD exacerbations, it is very likely that, when you give high oxygen, the carbon dioxide can go high and they can become unconscious because of CO2 narcosis. So in a COPD patient exacerbation, we are looking at a saturation of 88 to 92%. That's what I want to convey there.
Yeah.
So it's not a great idea to give the NRBM to that kind of patients. You can either try with nasal prongs, and depending on the situation, obviously we need to try with a non-invasive ventilation. That's what we need to do. We are not going for a high oxygen delivery to COPD patients. We are not aiming at that.
So there is next question is in the third question, if oxygen is given more also, it doesn't make any significant changes, was said. So what do we say as oxygen toxicity? I understand your question. It goes to certain level. Definitely PO2 goes up to say 400, 500 or 300. Okay. In the normal person, PaO2, the arterial content of oxygen, partial pressure of oxygen in the blood would be anywhere from 80 to 100. It goes up multiple times, like 300 and all that, it can go up. But only to that level. Beyond that, if you give more and more oxygen, say you give 100% oxygen for a very long time, the 300 cannot become 600, 600 cannot become 900. But that 300 can cause oxygen toxicity when it is given for a prolonged time, when it is not indicated. That's what I meant. I knew that was a little tricky question, but the message is not that if you give high oxygen, it will not cause toxicity. The message was, if you give more oxygen, will it increase your oxygen content beyond certain limit, was the question. It won't increase beyond certain limit, but of course it increases to certain level than the regular level. I hope you got my answer.
So that's the thing. So the oxygen content depends on the oxygen saturation. So whenever we increase oxygen beyond a level, naturally the oxygen saturation is not going to improve. So the oxygen content and the oxygen delivery is not going to improve. That is what is meant. But because if you just give high oxygen, basically there is a potential to cause toxicity. But oxygen delivery or oxygen content is not going to be altered.
I'm glad that this question raised some thinking amongst you, because I intentionally put this question. It was a tricky question. How do you set up HFNC? Ajit sir, you want to answer? Sunny Parmar has asked one question. How do you set up HFNC?
Yeah, you want to answer?
I can answer. So HFNC, as I said, predominantly the hypoxic patients, type 1 respiratory failure we call. The most of the evidence comes from there, that group of patients. Wherever you feel there is a hypoxic patient, to begin with, you can consider HFNC. Then you would have started already, you would have started oxygen mask or even NRBM, non-rebreathing mask. Then you can consider HFNC. You hope you have seen the device. There will be a humidifier, active humidifier. You have to maintain certain level of fluid in that. The distilled water, it comes a separate distilled water bottle comes. You connect it 1000 ml of bag or 500 ml of the container. You connect it to the heated humidifier, where it keeps slowly pulling the fluid by itself till it gets empty. The canister gets empty. You have to constantly keep monitoring that the bottle is filled. In a sense, you have to use a new bottle. It's like saline bottle, 500 ml or 1000 ml bottle. Make sure that it is full, because a dry, heated air causes a lot of discomfort to the patient. It always has to be humidified. Then comes the set. You choose, there are 2 sizes for the adult. Kids, I'm not sure about the sizes. For the adult, there are 2 or 3 sizes. The male size and female size, which is generally standard. It comes like a nasal pill, very small nasal cannula, very soft cannula with a strap which can be tied around the patient, and there will be a tubing. There will be a clamp also, so that the pressure does not fall on the mask and the nose. You connect it to there is a clamp which you can clamp it to the floor so that it doesn't hang on the gravity, hang to the gravity. Then you set up the device. You can, to begin with, as I said, you can choose temperature of 35 degrees, which is reasonably good. Then you choose the flows. If the patient is having too much of inspiratory drive, if he's struggling to breathe, then you can set up with 50 to 60 liters flow. Preferably, you can start with 30 to 40 liters flow. Okay, then the FiO2. You have to, as I said, it has to be connected to the central oxygen supply. There you can see the flow meter is up to 100 liter, if I remember, or 50 to 70 liters.
It's around 60 liter. You can.
The flow meter. It's a separate flow meter.
Flow meter, up to around 60 liters.
60 liters. You can choose 40 or 50. Then you see the comfort, oxygen saturation, how the patient is feeling, and keep assessing your ABG and whether the patient effort is coming, whether the patient is feeling subjectively better. That is the best assessment. In NIV and HFNC, the patient comfort and of course the respiratory rate, saturation, all these things you keep watching. If you feel that the patient is still hypoxic, you can increase the FiO2. You can start with 40 or 50%, then keep on going up to 100%. If it reaches 100 and if the patient is not improving, then if it's the situation allows, if we are doing awake prone ventilation, still oxygen not improving, then probably they are the candidates for invasive mechanical ventilation. I hope you got the answer.
So that's, yes, that's the thing. So in an HFNC means, so we are setting only three things. One is temperature. The HFNC, the machine, the machine which has got which is the knobs are there. In the knobs, you can set the temperature. Most of the time, we'll start with 34 degrees centigrade. So supposing, that is, for the patients who is, who is patient, who is self-breathing, breathing through the special cannula, nasal cannula. So if the patient is on a tracheostomy patient, we require more humidification, we can increase the temperature to 37 degrees. Sometimes, if the patient is uncomfortable, sometimes when the temperature is more, the patient can, for the humidification, you increase the temperature. You can, some patient can become uncomfortable. So you can decrease the temperature to even, 32 also. 32 also, we can make that. So we adjust the temperature, which I mentioned to you, that is with the knobs there. We adjust the flow. Flow also, it is made by adjusting the knobs. So we can make around 60 to 70 liters. That's 60 liters the flow, maximum flow we can generate from the HFNC machine at this point of time. And obviously, the flow and the temperature adjusted in the machine knobs. That, if you have a HFNC machine at your place, even the company person can demonstrate that we are on the bedside. We know the knobs can be there. And when coming to the FiO2 is made by increasing the flow. There is a special flow meter is there. You can sustain a very high flow. That flow meter, if you adjust the flow meter, you can adjust the FiO2. So temperature, FiO2 and flow are the thing we are, we are just changing. We are altering the HFNC. So for temperature and the flow is with the knobs there. You can increase the flow, decrease the flow. Temperature you can say 34, 37, 30. You can make like that. But if you want to increase FiO2, mean you have to increase the flow meter on the side, which you can adjust the FiO2.
The next question is how much oxygen will the reservoir bag supply to the patient? That is not how we talk about it. How much percentage of oxygen a patient gets when you use a reservoir bag is the better way of asking the question. Suppose you use reservoir bag in a partial rebreathing mask, it can provide up to 70 to 80%, 60 to 80% of the FiO2, fractional inspired oxygen. Suppose you use the reservoir bag on a completely non-rebreathing mask, which has 2 expiratory valves and 1 inspiratory valve, 3 valves. That mask can provide up to 90 to 100% FiO2, fractional inspired oxygen. So I would just reframe your question and given the answer. There is nothing like this reservoir bag, certain liters of oxygen. It's not like that. And you maintain, as I said, if it is a partial non-rebreathing mask, you have to maintain more than 8 liters, up to 12 liters. 8 to 12 liters if you maintain, then you will get 60 to 80% oxygen. If it is non-rebreathing mask with 3 valves, then you have to use 12 to 15 liter oxygen. That can provide 90 to 100% with a reasonably good bag, reservoir bag, at least matching the tidal volume of 500 ml or more. Then he can get up to 100%. Otherwise, it is up to 90%. I hope you got the answer. Abin Roy. Any other questions? Thank you.
Any questions are there? If there is no question, we can wind up the session.
Yeah.
So we would like to thank all the participants for actively participating in this session. I would like to once again thank Dr. Venkatesh Kumar for an excellent presentation. Thank you all. Thank you very much.
Thank you all. Thank you, Ajit sir.
Thank you. Thank you.
Thank you, ISCCM team.
Thank you. Thank you.